Hello everyone, I'm Dr. Aswathy Sunil and I'm a body imaging fellow at University of British Columbia, Vancouver. First of all, I'd like to thank the Indian Radiologist team for giving me this opportunity. I'll be talking about IgG for related diseases today. I'd like to extend my sincere thanks to my supervisor, Dr. Patrick Voss, for his guidance and his extensive collection of cases. I'd also like to thank my colleague, Dr. Samar Al-Shahri, for her contribution to this presentation. My objectives are to define IgG for related diseases, to describe the various systemic manifestations, to discuss the differential diagnosis, and to address the challenges in diagnosis. No disclosures. So IgG for related disease is a sclerosing disease which results in tumefactive fibrotic lesions. The disease progression is usually indolent, but can progress to organ failure. They show good response to steroids. The challenge is to accurately diagnose the disease, as it can often be mistaken for malignancies, infectious processes, or other immune-mediated conditions. The histopathological features include lymphoplasmacytic infiltration, styrofoam fibrosis, and obliterative phlebitis. So this is a slide showing multiple lymphoplasmacytic infiltration, and this is immunostaining showing IgG for positive plasma cells, shown by the brown-colored cells. This is a section from thyroid parenchyma. This is normal thyroid cells, and this is styrofoam fibrosis. And this is obliteration of the venous channel, suggestive of obliterated thrombophlebitis. IgG for positive cells, plasma cells, are required for the diagnosis of the disease, but sometimes it can be present in other inflammatory conditions as well. Also, serum IgG for concentration is often elevated in these conditions, but in 20 to 40% of cases, it can even be normal. So neither the presence of elevated serum IgG for concentration nor IgG for positive plasma cells are specific to the diagnosis of this disease. The American College of Rheumatology and the European League Against Rheumatism came up with a criteria in 2019. They assigned numerical points to imaging, histopathology, and serum IgG for criteria, and a total score of 20 points with no exclusion criteria is required for the diagnosis. As radiologists, what we should know is we can make a diagnosis of IgG for related disease solely based on the imaging criteria. So a three-step classification process was developed, which included an entry criteria, exclusion criteria, and an inclusion criteria. Firstly, it must be demonstrated that a potential IgG for related disease case has involvement of at least one of 11 possible organs in a manner consistent with IgG for related disease. The various organs are pancreas, salivary glands, orbits, kidneys, etc. Secondly, an exclusion criteria is applied, which consists of a total of 32 clinical, serologic, radiologic, and pathologic items, which must be applied. And the presence of any of these criteria eliminates the patients from the diagnosis of this disease. So the radiological exclusion criteria include malignancy or infection, rapid progression of the disease, long bone abnormalities consistent with earthen chester disease, or splenomegaly. Thirdly, 8 weighted inclusion criteria domains addressing the clinical findings, serological results, radiological assessments, and pathological interpretations are applied. The 8 criteria include histopathology, immunostaining, serum IgG for concentration. The rest 5 are predominantly radiological criteria, which includes salivary gland involvement, chest, pancreatic or biliary, kidney, and retroperitoneal involvement. Coming to abdominal findings, first is autoimmune pancreatitis. They usually occur in middle-aged and elderly men. There are 2 subtypes, type 1 and 2. It is a type 1 that is predominantly IgG for related pancreatitis, which is also called lymphoplasmacytic sclerosing pancreatitis. It can be diffuse, focal, or multifocal. Diffuse involvement is more common. They show diffusely enlarged pancreas with subsequent loss of normal pancreatic clefts, giving it the classical sausage-like appearance. On CT, they are usually hypoattenuating with a peripancreatic rim or halo. The fat veins are preserved without any vascular encasement. And on MRI, the capsule is typically hypointense on T1 and T2 with characteristic delayed enhancement. There can be restricted diffusion, and often the ADC values are lower than pancreatic carcinoma. So this is an example of autoimmune pancreatitis, where you see this bulky pancreas with hyperattenuating peripancreatic halo or capsule. This is MR of the same patient, where you see this T2 hypointense peripheral peripheral rim around the pancreas. Again, the pancreas are looking bulky. This is post-contrast MRI of the same patient with a hypointense halo around the pancreas. This is the same patient after a couple of years. There is significant reduction in the bulk of the pancreas, so this is suggestive of late stage of the disease. Coming to focal involvement, hyperattenuating lesions are seen compared to the normal background pancreatic parenchyma. They commonly affect the pancreatic head. So this is a 68-year-old male where you see a quite bulky pancreatic head and it is hypoattenuating compared to the background normal parenchyma. This is after a few months of treatment. There is significant reduction in the bulk of the head. So this was in fact biopsy-proven IgG4-related disease. So how to differentiate between autoimmune pancreatitis and pancreatic carcinoma? If you see a peripancreatic halo, and if there is no upstream duct dilatation, it favors autoimmune pancreatitis. As already mentioned, on MR, the capsule is T1 and T2 hypointense, and duct penetrating sign is seen while it is absent in pancreatic carcinoma. PET-CT is really helpful in some cases where you see heterogeneous and diffuse FDG uptake in the pancreas in autoimmune pancreatitis. Also, FDG uptake can be seen in extrapancreatic sites of the disease. While pancreatic carcinoma shows focal nodular enhancement with no extrapancreatic uptake, unless, of course, there is metastatic disease. Response to treatment. Radiological improvement can be seen within 2 weeks of treatment with corticosteroids. The main features include a reduction in the size of the pancreatic parenchyma, normalization of the pancreatic enhancement patterns, and normalization of the pancreatic duct diameter. In fact, we can actually predict the response to treatment. If there are features of early phase inflammation like diffuse swelling and a peripancreatic capsule, they suggest good response to treatment. They're predictors of good response to treatment. While features of late fibrotic stage like focal mass-like swelling or ductal strictures, they're usually predictors of poorer response. Next is IgG4-related sclerosing cholangitis. This is the second most commonly affected organ after pancreas, and it can be seen up to 60 to 80% of patients with autoimmune pancreatitis. We usually see a circular and symmetric rind of enhancing tissue encasing the bile duct wall with associated ductal stenosis and upstream dilatation. Most commonly, you see intrapancreatic segment of the CBD being affected. Gallbladder involvement can be seen. And the main differential diagnoses include primary sclerosing cholangitis and cholangiocarcinoma. So how to differentiate? Primary sclerosing cholangitis usually occurs in younger patients with IBD, usually associated with IBD. It's less acute, with longer duration of symptoms, and they have marked obstructive jaundice. On ERCP, classical prune tree pattern is seen, and the risk of cholangiocarcinoma is high. As already mentioned, IgG4-related disease typically occurs in older patients. They can have extrapancreatic involvement. The obstructive jaundice is less severe, and on ERCP, you can see long, smooth, and continuous strictures with a pre-stenotic dilatation. And the risk of cholangiocarcinoma is rare. How to differentiate between IgG4-related disease and cholangiocarcinoma? IgG4-related disease usually affects both pancreatic and biliary ducts. There will be no hepatic capsular retraction. The enhancing rind of soft tissue can be seen both at the stenotic as well as the non-stenotic segments. In cholangiocarcinoma, it is typically seen only in the bile ducts, and they can have hepatic capsular retraction. Soft tissue enhancement is primarily at the stenotic segment. So this is a 70-year-old male with IgG4-related prostatitis proven on top specimen. You see this dilated intrahepatic and extrahepatic biliary radicals with narrowing of the most distal aspect of the CBD. So this is suggestive of, sorry about that. So you see this narrowing only in the pancreatic part of the common bile duct. So this is suggestive of CBD. We also see autoimmune pancreatitis, features of autoimmune pancreatitis in this patient. This is a ERCP image of the same patient where you see a narrowing of the distal CBD with significant prestenotic dilatation of intra and extrahepatic biliary radicals. Coming to renal disease, it can be present in up to 35% of patients with autoimmune pancreatitis. Tubular interstitial nephritis is more common than membranous glomerulonephropathy. They don't present with hematuria. In fact, they're usually present with acute or progressive renal failure. It can be classified into 3 categories: parenchymal, pelvic, and perinephric disease. In parenchymal disease, usually you see bilateral round or bed-shaped opacities, predominantly in the cortex, and this is the most common pattern. There can also be diffuse patchy involvement. In the pelvic form, you can see bilateral nodules in the renal sinuses or even diffuse wall thickening of the renal pelvis. In the perinephric form, a rim of soft tissue is seen around the kidney. The main differential diagnoses include multifocal pyelonephritis, where the patient is usually feverish or even septic; lymphoma, where you can see multiple bulky retroperitoneal lymph nodes; vascular insult; renal cell carcinoma, especially if it's a solitary round lesion, it's really difficult to differentiate; urothelial carcinoma. Now, urothelial carcinoma usually causes renal tract obstruction, while IgG4-related disease usually doesn't cause renal tract obstruction unless it's associated with a concomitant retroperitoneal fibrosis. And finally, earthen chester disease. So this is a 70-year-old male with biopsy-proven IgG4-related disease. And you see this very vague hypodense areas in both the kidneys, very vague hypodense regions. And this is from 2017. This is the same patient from 2022, where you see more of a patchy involvement of both the kidneys. In fact, this patient had both autoimmune pancreatitis and IgG4-related cholangitis. This is another patient, a 67-year-old male. So this is from 2020, and he presented with progressive renal failure. Again, on kidneys, you see this vague hypodense round lesions in the cortex. And 4 years later, in the same patient, you see diffuse thickening of the renal pelvis. So over a course of few years, you see different patterns of the same disease in the same patient. So in fact, this was a non-targeted biopsy was done for this patient, and this was proven to be an IgG4-related tubular interstitial nephritis. This is an interesting differential diagnosis. This is a 68-year-old male who presented to us with new-onset anemia. And you see this diffuse perinephric soft tissue thickening, and even renal pelvis, there is some thickening and some round opacities in the parenchymal cortex, which is again seen on the coronal sequence. So we get the differential diagnosis of IgG4-related disease or lymphoma or even earthen chester disease. A bone marrow biopsy was done for this patient, and in fact, this was proven to be a primary myelofibrosis, and this was all, in fact, extramedullary hematopoiesis. So retrospectively, you can see there is splenomegaly in this patient. So according to the criteria, this IgG4-related disease should not be considered in this patient because splenomegaly is an exclusion criteria. Coming to retroperitoneal findings, it can be retroperitoneal fibrosis or lymphoplasmacytic aortitis. In retroperitoneal fibrosis, there is chronic inflammation in the retroperitoneum with fibrosis around the aorta and the iliac vessels. It can present as soft tissue mass, and it can cause hydronephrosis. This usually encases the vessel without any displacement, and it can extend cranially till the renal hilum. On CT, it can be seen as a soft tissue mass with variable enhancement. On MR, it's usually T1 hypointense. The appearance on T2 typically suggests a stage of the disease. For example, if it's T2 hypointense, it suggests chronic disease, and if it's T2 hyperintense, it suggests active disease. Similarly, even the enhancement pattern, if it shows early enhancement, it suggests an active disease. If it shows delayed enhancement, it suggests a chronic disease. Hence, imaging patterns assess disease activity and treatment response. The main differential diagnoses include malignant retroperitoneal fibrosis, lymphoma, where lymphoma typically displaces the aorta and extends above the kidneys. Earthen chester disease, especially if it's associated with long bone lesions, and retroperitoneal extramedullary hematopoiesis. So this is a 45-year-old male with elevated plasma IgG4 levels. And you see, this is a non-contrast study, and you see bilateral hydronephrosis with the soft tissue thickening anterior to the aorta. This is the same patient after treatment 1 year later. There is significant reduction in the bulk of that retroperitoneal lesion. This is another differential diagnosis. This is a 54-year-old female who presented to us with severe abdominal pain. And you see this diffuse kind of fat stranding in the porta hepatis and in the retroperitoneum. Maybe some soft tissue may be there. So we gave a possible diagnosis of IgG4 related disease. In fact, an ampullary biopsy was done and it was proven to be a poorly differentiated adenocarcinoma. And unfortunately, the patient passed away a couple of months later. Coming to lymphoplasmacytic aortitis, there will be non-stenotic aortic. This is a non-stenotic aortic mass causing aortic wall thickening and with irregular margins. It can progress to dissection, it can even lead to aortic aneurysm formation, but the prevalence of aortic aneurysm rupture is much less compared to aortic aneurysm caused due to other inflammatory conditions. This is a 62-year-old male, and on CT you see this diffuse periaortic soft tissue with intense uptake on PET scan. This is the T2 image of the same patient. You see it's predominantly T2 intermediate signal with some hyperintense area, and on post-contrast, the hyperintense area, which is presumed to be the active part of the disease, shows early enhancement than the rest of the lesion. This is the same patient after a few years, maybe 5 years. There is reduction in the bulk of the disease, but unfortunately, as you can see here, the patient developed aneurysms. He had delayed aneurysm formation. Coming to mesentery findings, it causes sclerosing mesenteritis, which is localized or diffuse fibrosis and inflammation of the small bowel mesentery. A soft tissue mass can be seen encasing the mesenteric vessels, typically at the root of the bowel. The association with IgG4-related disease is controversial, and hence it is not included as part of the ACR-ULR criteria. The typical signs are fat-ring sign, where there is a preservation of perivascular fat around the mesenteric vessels, tumoral pseudocapsule, where there is a band of soft tissue attenuation at the mesenteric borders of the mass, and sometimes in 20% of cases, specks of internal calcification can be seen. Prostate findings. It usually presents with prostatitis. It's an uncommon manifestation, and it's often under-recognized. Presents with enlarged prostate and obstructive uropathy, mimicking BPH and prostatic carcinoma. The PSA levels may be normal or elevated, which makes it challenging to differentiate from malignancy. On CT, there will be diffuse low attenuation of the prostate. On MR, it's diffusely T2 hypointense and with low ADC values. In fact, the entire prostate gland appears hypointense on ADC, while prostatic carcinoma, there will be focal area of hypointensity. And on PET scan, there will be diffuse tracer uptake. This is an interesting case. It's not exactly in the prostate. This is a 72-year-old male who presented to us with very early rectal carcinoma. And you see this T2 intermediate signal lesion just inferior to the prostate gland with short restricted diffusion and intense post-contrast enhancement. We did a transperineal ultrasound-guided biopsy of the lesion, which showed IgG4-related disease. He was treated with steroids, and in fact, there was a reduction in size of the lesion after a couple of months. So the abdominal findings are finished. Coming to the thoracic findings. Pulmonary involvement is common, occurring in up to 14% of patients, particularly in those with salivary gland and systemic involvement. The frequency of different thoracic involvement types varies and it's really not specific. There can be lymph node or pleural or lung involvement. Lymph node involvement is seen in 40% of patients, while pleural or lung involvement is seen in 14% of cases. Mainly 7 patterns are identified. Pulmonary, 4 patterns: nodular, ground glass opacities, interstitial disease, and peribronchovascular disease. In extrapulmonary disease, mainly 3 patterns: lymph node, pleural, and mediastinal fibrosis or retromediastinal patterns. Coming to pulmonary involvement. It can either be nodular pattern, where you see the small randomly distributed nodule, or it can be interstitial pattern, where you see this fine subpleural lines. It can be both posterior as well as anterior. The third pattern is peribronchovascular pattern, where it's a diffuse bronchial wall thickening. And fourth pattern is ground glass pattern, where you see this ground glass opacities. The extrapulmonary manifestation, first is lymph node. Lymphadenopathy is quite common and can be seen up to 80% of patients with lung disease. This is a 68-year-old male with biopsy-proven prostatic IgG4 disease, and you see bulky mediastinal lymph nodes. Next is retromediastinal pattern. A paravertebral soft tissue band can be seen, which corresponds to a thickening of the paravertebral sulcus in the lower thoracic region, involving 2 or more vertebrae in a row. This is mostly located on the right side. So this is a 60-year-old male, and you see this paravertebral soft tissue thickening more on the left side than on the right, and there is intense uptake on PET scan. We did a CT-guided biopsy, and this was proven to be related to IgG4-related disease. Pleural pattern, nodular or diffuse pleural thickening can be seen with or without pleural effusion. Any chest abnormality need not necessarily be related to IgG4-related disease. So a classification criteria was developed to assess the responsibility of the disease in obthoracic lesions. These include definite, where it's biopsy proven, highly probable, where typical imaging findings are there without any alternative explanation, and they show good response to treatment. Probable, where there is typical radiological findings with no alternative explanation, or possible, where the radiological findings are consistent, but there can be other plausible alternative cause. Next, coming to cardiovascular findings. Cardiac abnormalities include pseudotumor formation and pericarditis. They can also have aortitis with involvement of walls of large and medium-sized vessels. Assessing for coronary arteries is especially important due to the potential consequences, including myocardial ischemia. This is a cardiac CT of a 70-year-old male with known IgG4-related disease, and you see this diffuse thickening of the coronary arteries, which is again seen on these reconstructed images. So coronary arteritis and periarteritis, it can appear as diffuse arterial wall thickening, stenotic segments, and aneurysm formation. Next is dactyloadenitis and sialadenitis, Miclic syndrome and Kuttner syndrome. In Miclic syndrome, there is bilateral symmetrical painless swelling of at least 2 salivary glands. And in Kuttner syndrome, there is one or both submandibular gland involvement. Ultrasound shows diffuse or nodular low echoic areas with linear high echoic structures indicating fibrosis. On CT, they show enlarged glands with post-contrast enhancement. On MR, they're hyperintense on T1 and T2 with avid post-contrast enhancement. This is ultrasound image of a patient with biopsy-proven submandibular disease. So you see diffuse enlarged gland with diffuse hypoechoic areas and intervening hyperechoic areas with increased vascularity. This is another patient who presented with a lump in the neck on the left side, and this is left submandibular gland with increased bulky and increased vascularity. The right submandibular gland was normal. This was again biopsy-proven IgG4-related disease. So the differential diagnoses include viral infections like mumps, Sjogren syndrome, lymphoma, and sarcoidosis and granulomatosis with polyangiitis. If there is unilateral involvement, malignancy is a diagnosis of exclusion. Coming to thyroid findings, mainly 3 patterns are seen: renal thyroiditis, fibrous variant of Hashimoto thyroiditis, and IgG4-related Hashimoto thyroiditis. Renal thyroiditis is a benign fibrosclerotic disease with the strongest association to IgG4-related diseases. There can be fibrotic invasion of adjacent structures with mass effect, and the main differential diagnosis is anaplastic carcinoma. Next is fibrosing variant of Hashimoto. It's quite similar to renal thyroiditis with rapid enlargement and similar imaging features, but it doesn't cause any extrathyroidal invasion. So that is the differentiating point between renal and fibrosing variant. Next is IgG4-related Hashimoto thyroiditis. The affected thyroid tissue is diffusely hypoechoic at ultrasound. It need not be associated with other systemic manifestations of IgG4-related disease, as in renals, which may help in differentiating between the two processes. Next is orbital findings. Orbital pseudotumors can affect the entire orbit or just a few components, like extraocular muscles or optic nerves. It can be unilateral or bilateral. Perineural spread can be seen along the branches of the trigeminal nerve. On CT, they can be seen in soft tissue, which enhances. On MR, they're usually hypointense on T1 and T2 with avid post-contrast enhancement. The main differential diagnoses include lymphoma, fungal infections, especially if it's associated with sinonasal involvement, sarcoidosis, and granulomatosis with polyangiitis. If there is perineural spread, the potential differential diagnoses include squamous cell carcinoma, lymphoma, and adenoid cystic carcinoma. So this is a 79-year-old male with known IgG4 disease who presented to us with diplopia and retroorbital pain. And you see this soft tissue thickening in the intracorneal compartment of the orbit, which is hypointense on T2 and hypointense on T1, and there is avid post-contrast enhancement. Hypertrophic pachymeningitis. It's localized or diffuse thickening of the dura, and the lesions appear hyperattenuating on CT and isointense on T1 and T2 with avid contrast enhancement. The differential diagnoses include meningioma, meningeal tuberculosis, especially in India, neurosarcoidosis, granulomatosis with polyangiitis, Eartham-Chester disease, and lymphoma. So if there is these IgG4-related disease, they typically don't show any interlesional calcification. So if there is no interlesional calcification within the markedly due to hypertense lesion, they usually favor IgG4-related disease than a meningioma. And it usually affects the cerebral convexities. So this is pre-treatment image showing diffuse thickening of the pachymeninges and diffuse enhancement with reduced thickening and enhancement on post-treatment images. Hypophysitis. Involvement of pituitary can be involvement of anterior pituitary, posterior pituitary, or the stalk. And the imaging features are quite non-specific. It can be just enlargement of the gland or enlargement of the stalk with avid enhancement on post-contrast MR. As opposed to normal pituitary tissue, which is not FDG avid. Affected lesions are usually hypermetabolic and FDG avid. So this is, you see a diffuse thickening and enhancement of the pituitary stalk. This was a case of IgG4-related disease. So what are the challenges in diagnosing this disease? Usually the patients present with non-specific symptoms. There is often overlap with other conditions, which results in misdiagnosis. There are variable imaging findings. There is lack of awareness, which is one of the major causes of underdiagnosis in this disease. There are limitations to the serological testing of this disease. So there is a need for multidisciplinary approach, which is often not there. Even the biopsy is challenging. First of all, it's invasive, and even if you do the biopsy, it's a lot of the times inconclusive. There is also variability in diagnostic criteria, which results in inconsistent diagnosis and management. So a multidisciplinary approach that combines clinical, laboratory, and imaging findings is crucial for overcoming the diagnostic challenges of this disease. That's all for today. These are my references. Thank you so much for listening to me.